So, good morning to everyone. Buenos días a todos. And that's as far as my Spanish will go. My name is Miguel de Araújo Nobre. I'm the director at the MALO Clinic Research and Development Department. And my job here today is to get you a context on the presentations from my colleague, Dr. Carlos Morguedes, and my colleague, Antonio Silva, to see how PEEK could contribute to the maintenance of excellent long-term results. Of course, that when we started with the all-in-4 MALO Clinic protocol, this was the first study in 2003. I would like to pay a little tribute to this man, Professor Bo Rangert, which is no longer between us. He was basically the responsible for the existence of the all-in-4. He was the chief scientist at Noble Biocare at the time. And he made it possible that everything that Professor Malo projected could be real. This guy here was just a kid working at MALO Clinic at the time, and when these two approached him, said, well, kid, you've been working hard, so you deserve to be one of the co-authors of the study, but you're going to have to pedal. And then I pedaled, and I never stopped pedaling ever since. When we talk about the all-in-4, of course, that basic configuration with 2 anterior axial placed implants and 2 posterior tilted implants, everybody remember about surgery and prosthodontics. But then I ask, isn't this a 3-arm monster? What about maintenance? Because without maintenance, it's not going to be possible to get your excellent results. Of course, that I'm not talking about old school maintenance, brush like this, floss like that. Not that it's not important, it is. But I'm talking about modern maintenance in the sense of an epidemiological approach so that you can try and foresee the problems, profile your patients, and treat them better. So start solving the problems by preventing them. So when you connect the definitive prostheses, everybody's happy. The surgeon is happy, the lab technician is happy, the prosthodontist is happy, the patient is happy. But there's a whole lifetime to go through. And in this sense, it is important to have a strong team to assemble a protocol that can follow your patient. And more important than that, to get your patient accountable for what's going to happen to him in the long term. So usually, a lot of people think that the way to success is a straight line, and it isn't. It's a very messy road, a bumpy road full of curves. And a lot of things that you need to cover in both diagnostics and prophylaxis to get to this success. And if one of these issues is not so excellently taken care of, then the whole situation can break down and your success is gone. I like to learn from the past. I take very seriously that Google scholar saying, standing on the shoulder of giants. And so Professor Tonetti, genius, wrote a review in 1999 wherein with one graphic he explained his whole concept. So basically when you place the implants, you know your hazard ratio for implant loss is higher. And then that ratio goes down with time. However, as the follow-up increases, he projected also that you don't lose the implant as in lack of osseointegration or failure to osseointegrate, but some things start happening like pockets and bone loss. And so let's address this as peri-implant pathology. I think we all agree that peri-implant pathology is basically the main menace to excellent long-term results. Well, peri-implant pathology, why not peri-implantitis? Now this is where I make a small parenthesis on the presentation. So continuing on standing on the shoulder of giants, Professor Zarb, Koka, and Albertson wrote this amazing editorial of one page, which was brilliant, and I recommend you all to read it. Hyperbole, clinical dissonance, and scratching the surface, complication or disease. And bear with me, I promise this will be the only slides with a lot of text, okay? So quoting, we also continue to be critical of the use of the term peri-implantitis, since to do so implies a disease process similar to periodontitis, and we need to resist our profession's natural, anchored thinking regarding the tooth-host interface. What they were trying to emphasize here is that we must not fill the vacuum created by incomplete understanding of the implant-host interface with a reasonably coherent understanding of the tooth-host interface. What they preferred and proposed was a conceptual framework that can be supported by current knowledge of bone changes around implants, one that accepts the tenet that bone loss requires a multifactorial model to explain its occurrence, and that we do not yet understand all the factors to the degree needed to complete the model. And we fully agree with this situation. Actually, we fully agree with it since 2006. And you don't imagine the kind of trouble we go through fighting off the reviewers to maintain peri-implant pathology and not peri-implantitis on the studies. So now that we have the term defining the condition, we published this study very recently where we studied some attributable fractions for risk factors. Easy explanation of this is we attributed a weight to the risk factor so that we knew that by preventing it, how much percentage of cases we would be able to control. And in this study, we defined peri-implant pathology as a group of multifactorial situations that negatively affect the implant, but one where both biological and biomechanical factors intervene, and not so much that biofilm-mediated infection. So now that we have that term in the definition, what's the prevalence? One of the problems in estimating prevalence for peri-implant pathology comes from the different definitions of the disease. If you recall the Zitzman systematic review, Professor Zitzman, you'll see that it can go from 4 to 56% of the cases. What do you do exactly with those numbers? How can that be applied to my clinical practice? Well, for that, to get the answer to that question, we studied 22,009 patients on a prevalence study during 3 years, so that we could have, among other things, the prevalences for the main 3 chronic oral conditions. And we noticed that, we registered that the prevalence was 13.9% for peri-implant pathology in our practice. So, not the 56%, not the 5%, somewhere in between. So now that we have determined the definition and the prevalence, what do you do with it? So for you to get your excellent results on the long term, this is the strategy we usually apply. So you measure the risk, you manage the risk, and you communicate the risk. If you fail on one of these, then you'll increase exponentially the probability of failure. So let's go for the first. Measure the risk. We performed a body of literature on this subject, and we started with more than 30 variables to be compared. From these 30-something variables, there were 19, if I'm not mistaken, that were significant inferentially. But of course, one thing is for you to have a significant difference when you're comparing a variable between 2 groups. Another thing, is that variable sustaining its significance when controlled for the presence of other variables of interest? So what I'm trying to say is, what you really need to do to have a risk model, you need to place several variables at the same time in a model, like throwing something in the oven and then seeing who comes out alive. So after we studied this, second parenthesis, if peri-implant pathology, we studied this in more than 1,000 patients, if peri-implant pathology was purely the biofilm-mediated infection, how could it be explained that in the profile of the cases with peri-implant pathology, the first time bacterial plaque appears is here? Now, we are great fans of the Sander-Greenland model for chronic diseases. This model is the causation component model. Says that you have different manifestations of the disease based on the risk factors that are interacting with each other. And so I like to explain it a little bit easier. It's like pizza. You can have the manifestation of the disease with cheese, tomato, onions, and olives. But you may also have the manifestation of the disease and, oh, no olives here. It's bacon. So different pizzas, different outcomes, different pizzas, the same outcome. So different risk factors, the same outcome. Because implants are not exactly the same thing as teeth. And with this in mind, we tried to assemble our model. So we placed the variables all in the model, and we ended up building more than 25 models, and we guided our choice by accuracy. The number of patients that we could guess more correctly who had the disease and who hadn't. And the results, sorry about the large table, the results were these. So these were the predictors, okay? So in the model it fits history of periodontitis, bacterial plaque, bone level, smoking habits, bleeding, type of material used on the restoration, lack of prosthetic fit or non-optimal screw joint. Sorry about the big name. This means either the prosthesis does not have a passive fit, or you diagnose some prosthetic screw loosening or abutment screw loosening. Proximity to other implants or teeth, and an interaction between bacterial plaque and this variable. When you analyze the results here with the odds ratio, the odds ratio gives you the chance, increased or decreased chance, that a given patient with this factor will have or will not have the manifestation of the disease. So for example, a patient with no passive fit of the prosthesis will have 5 times more the odds, the chance of having peri-implant pathology compared to a patient without issues of passive fit. But how do you use these numbers on clinical practice? You don't use these ones. You use these ones. Use the beta values, statistical values. And with this, it's easy. You just put on your geek mode, allow me, and then solve this simple equation. And when you solve it, you will have a nice model with a very high accuracy. Okay, if we remove the geek factor, then it's easier to use a nice score system in points. If the patient has a determined characteristic, you score the point. If it doesn't, it's a 0. And then when you end up summing everything, you have a number. You have your profile of risk according to the numbers, and you can take decisions. But this is a little bit more easier than that. If you go to the Foundation for Oral Rehabilitation, it's free there. So you just log in, you go to Treat and Peri-implant Pathology Risk Assessment, and you just click on the questions. Perio, history of perio, yes or no? Plaque present, yes or no? Bleeding. Is the implant close to other implants or teeth? What kind of material restoration you used? Did you find any loosenings or prosthetic components, for example? Is the bone level located on the median third? Attention, I'm talking about bone level, not bone loss. This is just where the bone is at. And does the patient smoke? And after this, the site retrieves you with your point system, the profile risk of your patient, so measure the risk, the recall schedule that we propose, manage the risk, and you can download it on a PDF and give it to your patient so you can have him accountable for what's happening to him and start working on the issues that he needs to improve in order to maintain or come back to the excellent conditions at the connection of the definitive prosthesis. And you can do this anytime during your maintenance. So measure the risk, manage the risk, communicate the risk. So how could PEAK potentially contribute to the maintenance of these excellent long-term results, basically preventing the incidence of peri-implant pathology? This is, of course, under the focus of the study that was already submitted for publication, whose results my colleagues, Dr. Carlos Morguedes and Mr. Antonio Silva, were referring to previously. And so let's compare against the results that we found on this short-term evaluation. So let me get you a little context first. On the result, the correlation between plaque and bleeding. Professor Salvi and colleagues used 15 subjects to study how plaque and bleeding behaved under a condition of absence of oral hygiene habits for 3 weeks. So when they picked up the patients at baseline, they taught them everything they needed to know about their oral hygiene habits, and then they measured and they were perfect. No plaque, no bleeding. And this is what happened during the 6-week period. So on the first 3 weeks, we have uninterrupted plaque formation, and then prophylaxis, going back to the oral hygiene habits, and going through several evaluations on the following 3 weeks. And what you see is plaque and bleeding going between 1 and 133 for plaque and 133 and 1.5 for bleeding. What's this? So these are two very quick scales. They score between 0 and 3. 0, no plaque. 1, you insert the probe 1 millimeter into the sulcus and run a circle, and if you see plaque after performing that movement, it's a 1. 2, you don't need to do anything. You look and you can see plaque by the naked eye. And 3, you look and you can see that the patient had broccoli for dinner last night, for example. Bleeding, same scale, 0, no bleeding, 1, isolated bleeding spots, so kind of mild mucositis. 2, the blood forming like a ring around the abutment, and 3, heavier profuse bleeding. So what happened was, when you had a 1 in plaque, you had kind of a 1 in bleeding. And what you see is a sort of a linear positive relationship between plaque and bleeding over the following weeks. Then, at the prophylaxis, plaque levels dropped, but inflammation levels take a little bit longer. So they dropped also to half, but then they keep dropping, but then stabilized at 0.5. So you see kind of a negative linear relationship between plaque and bleeding. The interesting result about this in our study was that at 6 months, yes, we had a significant correlation, nevertheless not that strong, between plaque and bleeding. And at 1 year, there was a non-significant correlation with an increase in plaque levels, but a maintenance of stable, not stable, but mild mucositis on the bleeding score. So, interesting. Maybe it's not that linear about that biofilm-mediated plaque-induced peri-implant pathology, isn't it? Something more can be working on this value. So you see the results, 1 of plaque and then a 2, where I don't need to do anything. I see plaque already, but stable, non-changing score levels in terms of bleeding. And the marginal bone loss. The median value we found was 0.34 millimeters, which, considering the thousands of cases we have on all-on-4s, it's something that is a really good result of what we are used to see. Below average, clearly. And another interesting result was that the bimaxillar, sorry about the American term, because I took it directly from the journal, which is the Journal of Prosthodontics. So the Americans call bimaxillar rehabilitations double full arch. So the bimaxillar rehabilitations, average of bone loss was less than single full arch. Okay? It's not that big. If you see the 95% confidence intervals overlapping significantly, then forget about statistical significance, okay? But this implicated no peri-implant pathology yet. Okay, so going back to the risk score, what could peak infrastructure impact? It will not impact on the history of periodontitis, nor the proximity to other teeth or implants, at least in our study, because it's a full arch reconstruction. It won't teach your patients to brush and clean better. And bleeding, as you saw, it was present. And I'm sorry, but it won't help your patients quit smoking. But it will impact here. The kind of material that you use for the restoration, the lack of passive fit, as it is CAD/CAM manufactured, so basically it increases the probability of passive fit, and as you saw on the results, the bone level is really far from the implant's middle third. We're talking about 6 to 8 points of prevention here. It's a lot of points. So, as a summary, the absence of correlation between plaque and bleeding, a low marginal bone resorption, the low incidence of mechanical complications, and an absence of biological complications, for us, translates as a good prognosis for the long term. Okay, but then you go, come on, Miguel, you're taking conclusions out of a 1-year follow-up study. It's true, you're entitled to have that interpretation. Let's go back to this one. Remember this one. This is where we were. And by this time, we were pretty much murderers. So the tilted implants would fall, the prostheses would fail, and this would be a complete waste of time and effort. This was where we were then. Look at where we are now. So in a 7-year study, it's good. This is just to introduce you to the situation that at least give the benefit of the doubt. Let the time of the follow-up keep going, and let the data talk. Because the maintenance of excellent clinical results you get immediately when you connect the definitive prosthesis if everybody's happy. The maintenance of that excellent clinical result on the long term is very dependent on the patient and the compliance between patients and the clinicians. And so you don't need to plan in a 10-year overview. If you recall that movie, that Hollywood movie, The Fast and Furious, they had a saying, it's about street racing, okay? These guys race each other for their cars and money, and the races were a quarter mile. So there's a saying from that movie, I live my life a quarter mile at a time. We shouldn't live our lives a quarter mile at a time. We should live our lives a recall schedule at a time. So you don't need to plan for 10 years. You plan for the next visit. You plan and the patient plans. And this is our approach to how we should better keep the excellent clinical results over the long term. You plan on steps. And if I can leave you with an image, considering the different anatomical situations going on between teeth and implants, I would say probably that maybe PIC could be the next periodontal ligament. Thank you very much for your attention.